স্টুডেন্ট নাজনীন ম্যাডামের স্টুডেন্ট তো ওটা শুরু করি আমরা জান।
থ্যাংক ইউ ম্যাডাম, জয়েন করছেন।
ম্যাডাম অনেক সেই 9টার আগে ঢুকে বসে আছে ম্যাডাম।
দেখছি, ঢুকে দেখছি আমি ম্যাডাম।
হ্যাঁ হ্যাঁ জি, আসসালামু আলাইকুম, ভেরি গুড ইভিনিং টু ইউ।
অনেক ধন্যবাদ। ওয়ালাইকুম, ঠিক মতো এসে তোমরা খুব ভালো, শুরু করো।
Assalamu alaikum and very good evening to you all. Welcome you all to our weekly Oncology Club Gynae Oncology session. Our session is today journal presentation and debate. And today the journal presenter is Dr. Nazneen. She's Gynae Oncology student, is a final part student in BSMMU. And the debater are two, one from NICRS, another from Dhaka Medical College Hospital. From NICRS, Dr. Fouzia Sharmin, she is also HCPS Gynae Oncology final party student. And Dr. Yasmin, she is also a student Gynae Oncology final part from Dhaka Medical College Hospital. So, at first, I request our president of the Oncology Club, Professor M.A. Hi, sir. Please, sir, open the session. And then we'll start the journal presentation. Sir, please.
Thank you, Shana. Welcome to all the participants. Heartiest welcome and assalamu alaikum. As usual, we are starting this program. I have nothing to say more. Only to welcome you all and give my satisfaction and gratitude. It's because you are taking part. It's really very nice to me. Thank you all very much. Start immediately without any delay. Already 10 minutes past. Please, Shana, start.
Thank you, sir. Thank you very much. I request Dr. Nazneen to share her slide. Nazneen.
Thank you, madam. Can you hear me?
Yes.
With your kind permission, I'm starting my session. Honorable Chairperson, respected teachers and learned audience, Assalamu alaikum. A warm welcome to today's journal presentation session. I'm here, Dr. Nazneen Choudhury. Today, I'm going to present an original article, and the title is Concurrent Cisplatin-based Radiotherapy and Chemotherapy for Locally Advanced Cervical Cancer. The study was conducted by Peter G. Rose et al. And it was published in New England Journal of Medicine in 1999. I have chosen this paper because concurrent chemoradiotherapy with cisplatin is a standard practice based on this landmark trial. And New England Journal of Medicine is a reputed journal with high impact factor. This particular article was cited for 2,777 times. At the time of diagnosis, significant percentage of the patient with cervical cancer present with locally advanced stage, that is stage 2B onward, and pelvic radiation has been established as the standard definitive therapy for advanced disease. With pelvic radiation, the overall 5-year survival rate is approximately 65%. But the ability of the radiotherapy to cure locally advanced cervical cancer is limited by the extent of the tumor, because the dose that is required to treat the large tumor exceeds the limit of toxicity in normal tissue. To overcome this problem, various efforts are taken, like use of large particle radiotherapy, use of different radiation fractionation schedule, or concurrent use of hypothermia or chemotherapy. When chemotherapy is added over radiotherapy, there is some synergistic effect, like radiotherapy acts on local disease and chemotherapy acts on systemic. Concurrent chemotherapy acts by inhibiting the repair of sublethal damage and synchronizing cell to most radiosensitive phase of the cell cycle. And it also reduces the tumor bulk by cytotoxicity. When the protocol was taken, Radiotherapy along with hydroxyurea regimen was standard of care for advanced stage of cervical cancer, but myelosuppression was the limiting toxic effect with hydroxyurea, while cisplatin is less myelosuppressive and weekly dosing is possible with cisplatin. Since 1980s, many phase 1 and 2 trials are conducted, and it was concluded that pelvic irradiation can safely be combined with cisplatin, fluorouracil, and mitomycin. In a study shows that hydroxyurea, when combined with radiotherapy, there is increased complete response rate, in progression-free survival, and overall survival. But when concomitant treatment with cisplatin and fluorouracil is given in place of hydroxyurea, there is greater improvement in progression-free survival and overall survival. To assess the incremental benefit from the added chemotherapy, the Gynecologic Oncology Group performed a phase 3 randomized trial of radiotherapy combining with 3 concurrent chemotherapy regimen. That is cisplatin alone, cisplatin, fluorouracil, and hydroxyurea alone. It was a prospective randomized control trial conducted at 47 institutions of United States, and the study period was April 1992 to April 1997. The study protocol was accepted by the independent review committee of each participating center. Informed consent was taken, and all cancers are confirmed histologically by the GOG pathology committee. Randomization was carried out by a block arrangement, and treatment assignment were stratified according to center and clinical stage of the disease. Cervical cancer figures stage 2B, stage 3, and stage 4A with histology type invasive squamous cell carcinoma, adenosquamous carcinoma, and adenocarcinoma are included in the study. And the patient must have WC count more than 3,000 per cubic millimeter, platelet count 1 lakh per cubic millimeter, serum creatinine within 2 milligram per deciliter, serum bilirubin within 1.5 times the upper limit of normal for the institutional value, serum SGOT level within 3 times the upper limit of normal for the institutional value. The patient must have a GOG performance status of either 0, 1, 2, or 3, and there should have no history of other cancer. Those with disease outside the pelvis or interperitoneal disease or metastasis to parotid lymph node are excluded from the study. Before entry into the study, all patients underwent complete physical examination, pelvic examination under anesthesia, X-ray chest, intravenous pyelography, and CT scan of whole abdomen. All eligible patients got external beam radiotherapy. Then they are randomly assigned to receive any of the following 3 regimens. In group 1, cisplatin is given with radiotherapy. In group 2, combination chemotherapy, cisplatin, fluorouracil, and hydroxyurea is used. And in group 3, hydroxyurea is used along with radiotherapy. Radiotherapy is given in the form of external beam radiotherapy, followed by 1 to 2 insertion of intercavitary radiotherapy 1 to 3 weeks later. And the total duration is 10 weeks. External beam radiotherapy is given maintaining a strict protocol to the whole pelvic region in 24 fraction in stage 2B and 30 fraction in stage 3 or 4A. So in stage 2B, total dose received at point A is 80.8 gray and at point B 55 gray. And stage 3 and 4, total dose of radiotherapy at point A is 81 gray and point B is 60 gray. 1 week delay is allowed in radiation-related gastrointestinal or genitourinary toxicity. If WBC count goes below 2,000 per cubic millimeter, radiotherapy was withheld. Then the patient underwent any of the 3 chemotherapy regimen. In group 1, cisplatin is given at a rate of 40 milligram per meter square body surface area intravenously weekly for 6 weeks. In group 2, cisplatin is given at a rate of 50 milligram per meter square body surface area on day 1 and 29, and fluorouracil is used at a rate of 4 gram per meter square on day 1 and 29. Hydroxyurea is used at 2 gram per meter square or twice weekly for 6 weeks. In group 3, hydroxyurea is given at a rate of 3 gram per meter square orally twice weekly for 6 weeks. And chemotherapy drug dose modification is done according to severity of the adverse effect. If WBC count goes below 3000 per cubic millimeter and platelet count goes below 1 lakh per cubic millimeter, hydroxyurea or fluorouracil was discontinued. And if WBC count is less than 2500 per cubic millimeter, platelet count less than 50,000 per cubic millimeters, cisplatin was discontinued. Primary endpoint of the study was progression-free survival, and secondary endpoint was overall survival. Progression is defined here as 50% increase in the product of the two largest diameter of the primary tumor or metastasis. And progression-free survival is calculated from the date of entry into the study to the date of first physical or radiographic evidence of disease progression, death, or the last follow-up visit. And survival is calculated from the date of entry into the study to the date of death or the last follow-up visit. The study designed on the basis of an ability to detect a 35% decrease in the rate of disease progression with the use of either radiotherapy combined with cisplatin or radiotherapy combined with cisplatin, fluorouracil, and hydroxyurea. And this design provided the study with a statistical power of 80% with the use of log rank test at an alpha level of 0.025. And the target sample size of 165 patients for each regimen. The design called for final analysis when disease progression or death occur in 104 patients receiving control regimen, that is hydroxyurea, and 89 patients had died due to or disease progression. Lifetime estimate were calculated according to the Kaplan-Meier, according to the using Kaplan-Meier curve, and differences in progression-free survival were calculated with use of log rank test. The Cox model was used to adjust for prognostic factor and to estimate the relative likelihood of survival and progression-free survival. Pearson's chi-square test was used to detect differences in the incidence of adverse effect in 3 treatment groups. Interim analyses were conducted in May 1994, 1995, and November 1996. The performance of this interim test raised the type 1 error by only 0.05%. Now the result. Initially, 575 patients are enrolled, and among them, 49 patients, that is 9%, is found to be ineligible due to deviation to the surgical protocol for the evaluation of paralytic lymph node, ineligible stage of the disease, metastasis to paralytic lymph node, incorrect primary diagnosis, and incomplete pre-treatment testing. So finally, 526 patients are included in the study, and they are assigned randomly into group 1. 176 patients are included in group 1 and they got cisplatin. And in group 2, 173 patients and they got combination chemotherapy, that is cisplatin, fluorouracil, and hydroxyurea. In group 3, there is 177 patients who received hydroxyurea. And this is the table. There is no significant difference in the clinical characteristics of the patient among 3 treatment groups. And around 89 to 92% of the patient of all 3 groups are histology of squamous cell carcinoma. Now, about 50% of the patient present at stage 2B, and about 50% of the patient have tumor size more than or equal to 5 centimeter. Median duration of follow-up is 35 months. And after 24 months after the completion of the treatment, the progression-free survival is 67% in group 1, followed by 64% in group 2 and 47% in group 3 respectively. This is the Kaplan-Meier curve showing progression-free survival, showing the cumulative probability of progression-free survival on the vertical arm. And here, 109 patients out of 176 patients have no progression, and in group 1, and 106 patients out of 173 patients have no progression in group 2.
Nazreen, unmute yourself. We cannot listen. Unmute yourself.
Thank you, sir. But 73 patient out of 177 patient of group 3 had disease progression. So longer progression-free survival is observed in group 1 and group 2 than group 3. And the result was statistically significant. Can you hear me?
সামির প্রবলেমটা কি দেখো তো, এখানে একটা উইন্ডো আসতেছে মাঝখানে। সামির
এখন ঠিক হয়েছে তো নাজনীন?
প্রসিড করো।
নাজনীন কি আবার মিউট হয়ে গেল?
শুনতে পাচ্ছেন?
হ্যাঁ হ্যাঁ শোনা যাচ্ছে। এখন এখন আবার তো উইন্ডো আসছে।
শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে।
Can you hear me?
Yes, yes.
So this is the slide showing the primary endpoint of the study, that is progression-free survival. And in group 1, 109 patient out of 176 patient do not have any progression. And 106 in group 2. Hello?
Yes, we are hearing you. বলেন, আপনি শুনতে পাচ্ছি তো আমরা।
জি,
শোনা যাচ্ছে।
In group 2, 106 patient out of 173 had disease progression, but in group 3, 73 patient out of 73 patient out of 177 patient had disease progression. So it is obvious that longer progression-free survival is present in group 1 and group 2 rather than group 3, and the result is statistically significant. Survival curve. This is the secondary endpoint of the study is overall survival. And in group 1, in total death occur in 205 patient, and 59 patient died in group 1, while 57 in group 2, but 89 patient out of 177 patient are died in group 3. So survival rate is also significantly better in group 1 and group 2. And this result is also statistically significant. After completion of therapy, despite completion of therapy, in group 3, 30% of the patient had local progression. This rate is 1 to 1.5 times greater than group 1 and group 2. And 10% of the patient in group 3 develop lung metastasis, which is quite high, more than 2 times than group 1 and group 2. About 85 to 90% of the patient of all 3 treatment group can receive total dose at point A and point B. And median duration of the treatment is around 9 weeks in all 3 groups, but median delay due to toxicity is more in group 2, that is 10 days, while it is 8 days in group 1 and group 3. There is no treatment-related death, but toxicity like leukopenia, thrombocytopenia, and other hematological toxicities are more in group 2, while and the grade 3 and grade 4 hematological complications are also more associated with group 2, while in group 2 and group 1 and group 3, it is almost same. pelvic radiotherapy alone unable to control disease progression in 35 to 90% of the cases. Despite quite improvement, huge improvement in radiotherapy technique and equipments, progression occur even within the area that is irradiated before. So, combination of chemotherapy has been established, and it is the standard of care for improvement of the local regional control. Present study also showed that both groups that received cisplatin had a higher rate of progression-free survival and overall survival than the group that received hydroxyurea alone. Hematological toxicity is the major concern here, and grade 3 and grade 4 toxicities were more in multiple drug combination arm. The result is also supported by a phase 3 trial conducted by GOG, comparing radiotherapy with hydroxyurea with radiotherapy with cisplatin and radiotherapy with combination of cisplatin and fluorouracil, and there is improved survival in the 2-drug regimen. In a study conducted by Morris et al. Also showed that when cisplatin and fluorouracil is combined with radiotherapy, there is significant improvement in the rate of disease-free survival and overall survival among the patient of cervical cancer stage 1B onward. Present study showed that a significantly higher rate of progression-free survival and overall survival in the group that received cisplatin or cisplatin-based combination chemotherapy than the group that received hydroxyurea alone. But hematological toxicities were more in multiple drug combination arm. So the study results demonstrate the superiority of the radiotherapy with chemotherapy either with cisplatin alone or with cisplatin, fluorouracil, and hydroxyurea in patients with locally advanced cervical cancer over control arm. And treatment with cisplatin alone was less toxic than treatment with multiple drug regimen with comparable outcome. So the study recommends cisplatin as the standard drug for concurrent chemoradiation therapy for locally advanced cervical cancer. The study is well-designed, multi-center, randomized control trial, and all groups are well-balanced during randomization, and the study shows good compliance to radiotherapy and chemotherapy. And the weakness of the studies are, as it is a multi-center trial, so a question about the standard of radiotherapy can raise, and lack of multivariate analysis. And here conventional radiotherapy fractionation is used, so option of different fractionation is not observed. And as the radiation dose and duration is same in 3 treatment groups, so it is assuming that the difference in progression-free survival and overall survival is related to chemotherapy. The study did not assess dose-dependent late effect of brachytherapy on rectal or genitourinary system. And ability of carboplatin, which is a less toxic analog of platinum than cisplatin, and which is often used interchangeably with cisplatin, is not assessed in this study. So we cannot assume that the same result can be applied to carboplatin. Hello?
Yes. শুনতে পাচ্ছি, বলেন নাজনীন, শোনা যাচ্ছে?
জি জি। The study, along with 2 large randomized studies done by Keys et al. And Morris et al., are treated as landmark trials. So, and the result of these 3 trials are used as a reference for the use of concurrent chemoradiation therapy with weekly cisplatin for locally advanced cervical cancer. And thank you for patient hearing.
Thank you very much. Thank you, Dr. Nazneen, for your nice and brilliant presentation.
Thank you, ma'am.
Everybody is genius in this subject, but we cannot find out them. And our teachers, the teachers, Professor Haiser, Dr. Haiser, and all other the M. Shariful Alam sir, and all the members and the oncology club, they gave us the opportunity to conduct this session, gynae oncology session, and so we find these juniors. And thank you. At first, I request the juniors to comment about her presentation. At first, I request the junior doctors, any junior or mid-level doctors, please, anybody can come in front and comment on her presentation. Anybody? Is there nobody? Then I request Professor Dr. Farhana Dewan, Madam, to comment on her presentation. Madam, please.
Thank you very much, Shana Parveen, and with due respect to my respected teacher, Professor Kamal Bhai, I know them very well, and I'm really happy to see A.K. Goodman because she has been doing a lot of surgery. We have seen her surgery. Yeah, I'm so happy to see you. Actually, Nazin was my astronaut, so I know her, and I'm really proud that she's doing well and in your guidance as well. I have one question to Nazin. Nazin, you mentioned that you have seen the result. Let's not talk about Group 3 because Group 3 didn't do well in any performance. But regarding Group 1 and 2, because the results were more or less same, so you said that because only cisplatin after radiotherapy, only cisplatin has the combination has some toxic effect. So you will go for only cisplatin after radiotherapy. So is there any condition where the combination could have been used, or is there any advantage of the 3 combinations over cisplatin alone?
Nazrin?
Ma'am, actually, I have not go through such type of any condition where combination chemotherapy is used. Actually, when the study was done, at the time, hydroxyurea is used as chemotherapy agent along with radiotherapy. And then due to myelosuppression, another study was done which found that if cisplatin can be used, then myelotoxicity can be reduced. And and at the time, and they tried several other chemotherapeutic agents like fluorouracil or mitomycin, but the study result was not so much promising. And that's the reason cisplatin is used. And also in lung cancer and some other oropharyngeal cancer, some study using cisplatin have very promising result. So the study, as the histological basis, histological type are same, so cisplatin is used in cervical carcinoma. The study was done accordingly.
Is there anybody who can comment? Dr. A.K. Goodman or Dr. Kamal Bhai, please. Madam,
that was a
yeah, A.K.
that, oh, first of all, that was a really good presentation. I would say congratulations, and you basically modeled for everybody else the way you should analyze the paper. So I'm really impressed and very grateful for your great analysis. So
thank you.
Wonderful work. So it's really exciting and just wonderful to listen to you. It occurs to me there's these 5 important studies from about 20 years ago that really, I think, changed the standard of care in high-risk cervical cancer.
Yeah.
In terms of changing from radiation alone to chemoradiation, right? So we have these series of studies. They all came out around the same time, which is also very interesting. Just how the world works, where the concepts kind of happen at the same time. And I ultimately think that probably it doesn't matter what chemotherapy agent you use. I think maybe that's the final conclusion, because what it is that chemotherapy is a potentiator for radiation, right? It's being used in a different way than using chemotherapy by itself as a cytotoxic. Increasing the ability to have oxygen-free radicals that allow better cancer-cytal dosing, and whatever that is on a molecular level. So whether it's hydroxyurea, whether it's cisplatin, whether it's a combination cisplatin 5-FU, I suspect it probably doesn't matter. I think that's what the message is. So you choose what you're going to do based on availability, maybe based on cost, and based on toxicity. So in this particular study, we really learned that hydroxyurea had a higher toxicity, right? So potentially you would use cisplatin or cisplatin 5-FU. If you are in a setting where the costs of infusion are such that you would do a pill, that would be less costly to get the survival rates and the progression-free survival rates that you want, it's fine to use hydroxyurea. You're going to have more mucositis potentially. You're going to have more leukopenia. I am interested in, Dr. Kamal, what your thoughts are in terms of how it is that chemotherapy generically potentiates radiation. How does that work exactly? If maybe you could comment on that.
Thank you, Ike. First of all, I want to congratulate Nazreen, because I was telling to her that she should do justice to her potential. And I can tell Nazreen that you have done real justice to your potential. As Ike said, it is one of the best presentation I have ever heard. Really, congratulations to you. It was a real good presentation. So coming back to the question of Madam, the very proud teacher, today you should be proud of your ex-assistant registrar, who have really done a wonderful job. So yes, Ike was telling, Madam, at the same time, 3 to 5 study came out. It is quite surprising. The different part of the world, many people were working, and they were working sometimes with a single drug, sometimes with a multiple drug. But the interesting is, majority was working with cisplatin. So in all the combinations, cisplatin was there. So when they found that the effectivity with single drug is same than combination drug, and so the toxicity is less. So finally, the final recommendation came out that cisplatin is the preferred drug for concurrent chemoradiotherapy in cervical cancer. As Nazreen said, this is also a use we use in head neck cancer also. But what Ike was asking, that how it works. It works, say, we know in radiation, there is some sublethal damage. That radiation kills some single-stranded DNA break, which can be repaired automatically. But when we add cisplatin, then cisplatin also causes another sublethal damage. So 2 sublethal damage make a total lethal damage. That is, say for example, radiation break 1 DNA, 1 strand, and cisplatin breaks another strand, so it becomes a total damage. So this is how cisplatin potentiates the effect of radiation, number 1. Number 2, it also pulls the cell from less cytotoxic, less mitotic pool to more mitotic pool. So cisplatin is a drug which acts on all cell cycle phase, but we know radiation act more on the mitotic phase. So if some of the cell who were in a non-mitotic phase where radiation was not much effective, cisplatin can take care of that. And also it is not big dose, but still there is a belief that this amount of cisplatin take care of some part of the distant metastasis. So to explain, we always say that the dose of radiation was used with the use of this cisplatin potentiate the efficacy. So at the cost of 50 gray radiation, we are getting something about much more when we are using this cisplatin. So it is a radiosensitizer. We say it is a radiosensitizer. So it sensitizes the cell, as Ike was telling, making more oxygenation, causing more cell killing, And yes, at a cost of some toxicity, but it is acceptable. Madam, if there is a situation where a patient is not eligible for cisplatin, we can use, as she was telling, we can use carboplatin, we can use paclitaxel, we can use docetaxel. There are many other options which is less nephrotoxic. But we always should use chemotherapy because it is seen that without chemotherapy, only radiotherapy is not enough to take care of advanced cervical cancer. Thank you.
Thank you, Kamal bhai. Now I request Professor Saiba madam. Saiba madam, please. She is with us. Professor Saiba madam.
Thank you very much. Assalamu alaikum.
Ji madam.
Shahana, actually, I am just listening in the middle, so I am really impressed by the presentation of Nazneen. I am not expert in your field, so it's I think at this moment it's better for me not to comment, but I'm really impressed and proud of Nazneen and also Shahana for you. I like to thanks and congratulate and express my gratitude to Goodman because she is helping us, our young doctors, and also indirectly she is helping our patients all the times. We all Bangladeshi doctors are grateful to you. I hope you will continue it and our doctors will get more and more chance to update themselves. And it's very good initiative. As a whole, I congratulate our oncology club, and Kamal also is there. So thank you everyone. It's the first time I'm attending. I wish to, I will get the opportunity to attend it regularly. That will update myself also. Thank you so much, Shahana, for sending the link. I have joined at the cannot attend from the beginning. So inshallah we'll be with you in future programs.
Thank you, madam. Thank you very much. Madam, we are very happy that you are now in Toronto, and from there you are joining with us. Sir, our oncology club president, Professor Hai sir, is every program he is with us. So his inspiration will just give us the courage. So please, sir, madam, pray for.
I just came back today, just I was so tired and having
madam.
hangover. Anyway, nice to hear Sai sir.
Shahanara Chaudhary, madam. She's from head of the department, Chittagong Medical College. Shahanara Chaudhary, madam. Shahanara Chaudhary, madam. Probably she is not.
Assalamu alaikum to everybody, and thank you very much, the oncology club and the patron and the speaker. I missed the presentation. I'm very sorry that I missed because of some problem in my network. From 7 it was absent, so I'm very sorry I missed. Nazneen, your excellent presentation. I hope it will be in the video. So my heartfelt thanks to Shahana. Every time he phoned me, why you are not entering into the webinar. Actually, I am trying, but because of the network, and I love the oncology club, I want to be a part all the time. She phoned me, I joined it. So, but today, because of this problem, and Goodman, thank you very much for your excellent interaction in the teaching learning session. And I hope you will continue, and inshallah, I will join in the future every part of the oncology session. They have a wonderful session. We learned a lot from these sessions, and we are hoping that in our other club also we have to come forward for the future generation. Thank you very much. Thank you.
Madam, thank you very much. Now I request Dr. Jannatul Firdaus. She wants to, she have a question. Dr. Jannatul, please ask your question.
Thank you, Professor Shahana Parveen. Respected chairpersons, my teachers, and my gynae onco mentor, A.K. Goodman. Good morning and good evening, because we are, you are from the West. So for you, good morning. At first, I'd like to give thanks to Nazneen Dr. Nazneen for her landmark presentation. I should say it's a
Thank you, madam.
landmark presentation, and a very good topic has been selected. Really, it is a very good paper, which was published in 1999 in a very good high impact factor journal, New England Journal. Actually, in your paper, my question to you, I have two questions. You have shown that in the cisplatin group, in hydroxyurea and fluorouracil group, that is group 2, the drug was stopped when WBC count was less than 3,000. And in group 1, that is in cisplatin group, the drug was stopped when WBC count was less than 2,500. I just want to know why this variation, whether the cause was discussed in anywhere in the discussion. This is one. And second question is, what do you think? Is there any confounder in this study, like histopathology? I didn't listen about the adenocarcinoma, and also performance status, because a wide range of performance status was taken in this study. It was
Sorry,
from
madam.
0 to 3. It was from 0 to 3 has been taken. So my question is, what do you think? Is there any confounder in this study? And my one comment regarding this topic, already it has been discussed that if radiotherapy, only radiotherapy is not better, overall survival, progression survival is better when concurrent chemoradiotherapy is given. So if we can show the results of the comparison between only radiotherapy group and concurrent radiotherapy group, probably in the next journal, that would be better. How the evolution occurred, that is, when only radiotherapy was practiced, what was the result? And when concurrent chemoradiotherapy was practiced, what is the result? So thank you. I think, AK, you can also comment why.
Sorry, madam, can you repeat the question? Sorry.
Please repeat the question, Jannatul.
Okay, my question is, in hydroxyurea and fluorouracil group, that is group 2, WBC count when become 3,000, the drug was stopped. Both the drugs were stopped. But in group 1, that is cisplatin group, it was stopped when WBC count was less than 2,500. I want to know the variation, whether they describe in the discussion segment. And another question, what do you think? Is there any confounder in this study, like histopathology or performance status? Because wide range of performance status
Sorry,
was
madam.
included. Can you hear, Dr. Nazneen? I think, AK, can you answer?
Sure. So for the first question, that's a great question, and I have had in my life the great privilege of going to GOG meetings. They're now called NRG, but basically you go to these committee meetings and you have this big group of people and everyone's sitting around the table, and then there's a big audience behind, you know, the little people who are not at the big table, and they're kind of going through how they're going to make the new test and the new study and this and that and the other. And sometimes certain things come out that get put into protocols that are hard to understand, that are related to consensus. I think probably the reason for the variation in that particular white count limitation has to do with the toxicities of the hydroxyurea versus cisplatin. But you're absolutely right. It does it's a confounding factor in terms of the groups are slightly different. Does it matter? I don't know if it matters, because I mean, clearly in terms of their performance status, it didn't matter, and you still had more toxicity in the hydroxyurea group. So maybe they were right. But probably if you wade through the fine print of the appendixes, you might find the explanation for that. So that would be my thought about that. In terms of performance status, that's a really great question. I mean, I think that status is a good right? So you can and look at them and you kind of know how are they going to do. So someone with a performance status of a 1 or even a 2, you know, they probably are going to do fine, you know, in terms of treatment. By the time you get to a performance status of 3 and clearly 4, you know, they're probably not going to do so well. So it also can be a confounding factor in outcomes, right? Because just based on that performance status, you would hope that by a multivariate analysis, you are able to sort out those fine details. Anyway, I'm curious what other people think about that. That's a great question, both of them.
Madam, actually, I didn't found any confounding factor in the total study, and there is no comment regarding the performance status. So sorry, I can't answer properly to your question. Kamal sir, can you help me, please?
What AK said, what we do for any chemotherapy, we look at the total count of the WBC, but more than that, go. The main reason of this, as AK mentioned, that hydroxyurea has an inborn tendency of doing myelosuppression compared to cisplatin alone. So in that group, there was 3 drugs. So they took a higher level, and when it is a single drug, they took a lower level because they didn't want a treatment interruption. We know that in cervical cancer treatment, the total treatment duration is a big issue. And you can see if the group 1 and 3 was 8 days. So this is the reason why they have taken an upper limit when there is a triple drug, including hydroxyurea, and where it is a single drug. And yes, regarding confounder, yes, there is a wide range of performance status. They have taken squamous, adenosquamous, and adeno. And in the limitation, they have declared that they failed to do the multivariate analysis as AK said. So that is the weakness of the study. But as Jannatul mentioned, that this is a landmark trial, and it is one of the 5 trials which established the role of concurrent chemoradiotherapy as the standard of care for advanced cervical cancer. And in question, she was telling that comparison of radiotherapy and chemoradiotherapy. Yes, that is a great idea. Hopefully we can select that paper. But in this paper, they have taken ground as the this radiotherapy and hydroxyurea as a standard, because till that time when this protocol was designed, hydroxyurea and radiotherapy was the standard of care, not radiotherapy, because before that there was a GOG trial which has shown that hydroxyurea plus radiotherapy was doing better than radiotherapy alone. So as per the suggestion of Jannatul, I think, Shahana, we can select that paper to see the evolution of the treatment of cervical, that how it evolved from radiotherapy to radiotherapy plus hydroxyurea, then from hydroxyurea to cisplatin.
Yes, there is another question. Is question from Dr. Riyad, that is why in this study paraotic lymph node is excluded from this study. The question from Dr. Altaf Hussain Riyad.
So let me help Nazneen to answer. Riyad, you know, this is a classical treatment portal of pelvic radiation. And you know, when there is a paraotic node, then it is a total different story. The outcome is much less, survival is worse, and we need to have a different portal of paraotic radiation. So to make a even level playing field. So they have taken within the pelvis and they have excluded parietic node. Because in this type of study, if you really select parietic, then it will become a more challenging thing to compare because it will not be apple to apple group because we know parietic node metastasis is a worse outcome. So that's why they have intentionally taken out the parietic group as an exclusion criteria.
Thank you, sir.
Can I supplement, Kamal bhai?
Yes, please.
I think the inclusion criteria, as Dr. Nazneen has mentioned, that it is all the locally advanced cases, that is from stage 2B to stage 4A. And when the parietic lymph nodes are involved, it becomes stage 4B, that is distant metastasis, because parietic lymph nodes are not the regional lymph nodes in case of cervical cancer. So the parietic, when the cases with parietic node involvement has been excluded in this study.
Thank you, madam.
Thank you very much. Thank you. Now we will go for our next session. Our next session is
AK want to say something.
Oh, I just sent you all a link. This is if you just click on it, it will give you a definition of confounding factors. It's actually very good. It just for you to know, that's just a general term in your data that you may not be thinking about, but that may change the interpretation so that it's not completely true, perhaps, or perhaps it's got some errors to it. All right, it's not as robust. So when you're developing research and when you're evaluating other people's studies, you think about confounding factors. So in the paper itself, in a really well-written paper, in the discussion, there will be a section on strengths and weaknesses. And you talked about that in your wonderful presentation today. But in that limitations, you usually try to think about what is it you didn't think about, what could potentially cause an error to your data, or confounding influences, so like a performance status or something like that. So just there's a link there. It's a good read. Just gives you examples of other situations for your interest.
Thank you, AK. Thank you very much. It is around 10 p.m. here, so we'll go for our next session. You please stay with us. Yeah. Okay. Now is our debate session. The debate topics of the debate is
Ai taha.
our debater. The first debater is Dr. Fouzia Sharmin, and the topic of the debate is advanced imaging with PET CT and MRI is a must for the management of cancer cervix in our country. She will talk on favor of this topic. Dr. Fouzia Sharmin, please.
Thank you, madam.
Please share your screen.
এটা
স্লাইড শেয়ার করেন, যে নিচে কাপের মতো ওইটার মধ্যে ক্লিক করেন নিচে। ইয়েস,
Can you hear me?
yes.
Thank you, Madam. With your kind permission, I am starting the session. Honorable Chairperson, respected teachers and learned audience, Assalamu alaikum. Today's debate topic is advanced imaging with PET-CT and MRI is must for the management of cervix cancer in our country. I am Dr. Fauzia Sharmin, FCPS Part 2 student of Gynecological Oncology and ICRH. I will be in favor of this topic. The staging system of cervical cancer is based on physical examination and inspection. It was aimed to easily introduce in non-developed nations with limited access to imaging studies. But when clinical staging was compared with surgical staging, there is a difference in stage 1B, 32%, and stage 3, 65%, which was published in Gynecological Oncology 1980. The huge difference is observed because of inherent deficiency of clinical staging, which cannot be evaluated properly, that is tumor size, pelvic sidewall invasion, parametrial invasion, and nodal metastasis. These are the important prognostic factors. So FIGO has incorporated MRI and PET-CT in 2018, considering the accurate pretreatment evaluation for selection of initial treatment modality. FIGO Cancer Report 2018, which was published in International Journal of Gynecology and Obstetrics, showed that MRI is best method of radiological assessment of primary tumor greater than 10 millimeter. For detection of nodal metastasis greater than 10 millimeter, PET-CT is more accurate with false negative result in 4 to 15% cases. In ESGO, ESTRO, and European Society of Pathology Cervical Cancer Guideline, pelvic MRI is mandatory initial workup for assessment of pelvic tumor extent and to guide treatment options. PET-CT is the preferred option for treatment planning before chemoradiotherapy with curative intent. The reason behind this imaging is that it improves the single modality of treatment, as dual modality of the treatment is associated with significant morbidity. Fertility sparing surgery, accuracy of highly precise radiotherapy, evaluation of surgical resectability if pelvis is the sole site of recurrence, identifying the complication of the disease and its treatment. My opponent can argue that ultrasonography and CT scan can be used as staging purpose. But here is a comparison study which is published in European Review for Medical and Pharmacological Sciences. Comparison was done between the MRI, CT scan, and contrast-enhanced ultrasonography in the diagnosis of cervical cancer staging. Here, accuracy of the MRI is better than CT and ultrasonography is shown. In stage 1B, the accuracy for MRI is 74%, where CT scan is 60%. In stage 2, it is 75% for MRI and 69% for CT scan. In stage 3, 85% in MRI group and CT scan 78%. And all these are statistically significant. There's another study comparing the CT scan and MRI for preoperative staging. And they clearly showed that MRI was 88% accurate in evaluating the stromal invasion and more accurate, that is 94% than CT scan. CT scan is 76% accurate for assessing the parametrial invasion. And in determining the operative candidates, MRI was 94% accurate compared with 76% for CT scan. There is another study which is published in Gynecological Oncology. Here shown that MRI, to rule out the bladder and rectal invasion, MRI has a 100% negative predictive value in detection of the bladder and rectal invasion. That can avoid the cystoscopy and endoscopic staging, and which will reduce the cost and morbidity. Regarding the PET-CT in recurrent cervical cancer, This review article, which is published in 2014 February, which showed that PET-CT is valuable method for assessment of para-aortic lymph node and recurrent cervical cancer, especially to detect the distant metastasis and locoregional recurrence. Another study review article published in Frontiers in Oncology, the role of PET-CT in cervical cancer. In locoregional control, concurrent radiotherapy is still a problem. Tumor microenvironment with hypoxia and angiogenesis can be a factor in this regard. PET-CT has tremendous impact on evaluation of the treatment response. There is another study which shows the clinical impact of PET-CT on treatment choice in recurrent cervical cancer. And it shows that there is a variation about 20 to 48%. PET-CT has, based on prognostic nomogram for locally advanced cervical cancer. Another study is published in Gynecological Oncology in 2012. Here, Kidd et al. Reported that standard uptake volume of pelvic lymph node is a prognostic biomarker predicting the treatment response, pelvic recurrence risk, and disease-specific survival. My opponent can say that these modalities are expensive, but dear opponent, with this imaging, we can ensure the proper selection of treatment modality, we can avoid the dual modality of the treatment, we can improve the quality of life, especially the lymphedema, which is lifelong complication for the patient, better treatment outcome is possible. So I think this is justified when I am getting all this benefit. So no more debate, let us agree. Thank you.
Thank you very much. Thank you, Dr. Fouzia, for your nice presentation. Now I request Dr. Jasmine Sultana. She is FCPS Part 2 Gynae Oncology student from Dhaka Medical College Hospital. She is against this topic. Dr. Jasmine, please.
Can you hear me?
Yes.
Thank you, madam. Respected President, my dear colleagues, Assalamu alaikum. Respected President, my dear learned colleagues, Assalamu alaikum and very good evening. I am Dr. Jasmine Sultana, Gynae Oncology subspecialty student, Dhaka Medical College Hospital, participating in today's debate on advanced imaging with PET-CT and MRI is a must for management of cervical cancer in our country. I am against the topic. One can say, that MRI and PET scan is highly important, useful imaging tools for management of the cervical cancer. But in context of our low resource country, these tools are not so affordable and available as highly developed countries. So question can arise in our mind that what imaging tools is suitable for our low resource country? NCCN resource stratified and harmonized guidelines, a paradigm for optimizing global cancer care, published in 2020 by Weijin, an article shows that the most frequently used guidelines are developed for highly researched system. Oncology published in 2012 shows an article that is consensus meeting and update on existing guidelines for management of cervical cancer, with especially in practice in developing countries, including India, with the assistance of Tata Memorial Hospital. The article shows in a minimum setup situations, at least an if any, with documentation of presence of cross-pelvic and para-aortic nodes. For advanced stage, both computer tomography and MRI were seen by equity to identify the nodal involvement. An article published in 2019 by Maria Milagros, Role of MRI in Staging and Follow-up of Endometrial and Cervical Cancer Pitfalls and Mimickers, shows that microinvasive tumors cannot be delineated by MRI, thus plays no role in evaluation of stage 1A lesions. A false positive estimation of vaginal invasion occurred when the vaginal fornix is stressed by a bulky exophytic cervical tumor. MRI has other pitfalls too, that is, it is expensive, time-consuming investigation. Actually, ill patient cannot cooperate, so artifacts may result. Great technological expertise may be required. Patients with pacemaker cannot be, appliances cannot be studied. The article FDG PET Assessment of Cervical Cancer, published in 2018 by Chitra Vishwanathan, shows that PET-CT may be of limited usefulness in the early stage MRI lymph node negative cancer. It had shown low sensitivity for lymph node involvement. FDG uptake in brown fat, which can be distinguished from lymphadenopathy, is characteristic distribution in the neck, thorax, and absence of lymph nodes in the area of uptake. Infection or inflammation can also have FDG uptake and mimic malignancy. Other limitations of PET scan is very expensive and not readily available. It is accurate in certain situations, that is, slow growing, less active tumors may not be observed much tracer. Small tumors less than 7 millimeter may not be detectable. They often accompany other scans such as CT scan and MRI in order to be diagnostically effective. So for our research limited country, ultrasound and CT scan are easily available, affordable, and less time-consuming imaging tool for management of the cervical cancer. The worldwide acceptance of ultrasound is in the assessment of the cervical cancer has significantly increased over the past 2 years. Here there are two figures showing ultrasound and Doppler evaluation of the cervical cancer. A European multi-center trial published in Gynecologic Oncology on 2013 by Elizabeth Epstein is early stage cancer, cervical cancer tumor delineation by magnetic resonance imaging and ultrasound, shows that ultrasound is as highly accurate as MRI for the pre-operative assessment of early stage cervical cancer. Ultrasound may be more accurate than MRI in detecting residual tumor and assessing parametrial invasion. Here, another study published in Gynecologic Oncology Report, August 2018, is imaging and cancer of the cervix in low and middle income country. They show that the preoperative transvaginal and transrectal ultrasound examination provided 96% accuracy for cervical tumor with the 90% sensitivity and 97% specificity. Color and power Doppler interrogation frequently demonstrate increased vascularity of the cervical cancer that indicate aggressiveness of the tumor and is associated with higher risk of stromal parametrial invasion and metastatic lymphadenopathy. Here is another study published in International Journal of Gynecological Cancer on July 2008, the transrectal ultrasound and magnetic resonant imaging in staging of early cervical cancer by Ficherova et al. They Goal of the study is to determine sensitivity, specificity, and accuracy of the transrectal ultrasound in comparison to MRI in early stage cervical cancer. And the result shows accuracy of the transrectal ultrasound was superior to MRI in every early stage cervical cancer, especially in detection of the residual tumors following conization. This study was published in Gynecologic Oncology Report and shows CT scan is more cost effective than MRI and more widely available worldwide, particularly in developing nations. Lymphatic spread of cervical malignancies can be readily assessed by CT scan. Nodes more than 1 centimeter in short axis diameter are considered abnormal. Ureteral encasement with resultant hydronephrosis is consistent with stage 3B disease. So the take-home message is transvaginal and transrectal ultrasound provide 96% accuracy for tumor detection. Transureteral ultrasound is superior to MRI in early stage cervical cancer. Color Doppler ultrasound demonstrate aggressiveness of the cervical tumor as well as stromal and parametrial invasion and lymphadenopathy. Lymphatic spread of cervical cancer readily assessed by CT scan, and CT scan is very effective and efficient aid for staging of the cervical cancer. So on the basis of discussion and references, we can come to the conclusion that although MRI and PET-CT are superior imaging tools, but not mandatory for management of the cervical cancer, in low resource country like ours, where ultrasound and CT scan are more acceptable and affordable options than MRI and CT scan. Thank you all for patience hearing.
Thank you very much. Thank you, Dr. Jasmine, for your nice presentation. Now I ask anybody, from any level, including our junior doctors, you please, can ask your question and anybody can comment on these two presenters' presentation. Anybody can come forward, please. Is there anybody who can comment?
Hello, madam. I'm Dr. Rupa, radiologist. Can I say something?
Yes, yes, Rupa.
Yes, madam. Hello.
Yes, yes.
Yeah. First, I'd like to thank Oncology Club. This is excellent idea of this debate about the burning issue. Which modality is the preferred for the cervical carcinoma? So both the presenters, the debaters are the excellent. They give their presentation. So now I'd like to comment my opinion about and our experience. MRI is the best modality of choice, no doubt, because in cervical carcinoma, the pelvic structures, all the soft tissue, and in all cases, actually PET-CT is not the preferred modality. We use, according to AGCC guideline, PET-CT we recommended when it is extra pelvic nodal metastasis, para-aortic, or bony metastasis, then we go for PET-CT. And ultrasound, CT is not the preferred modality, and ultrasound is the screening only. So that is my opinion, ma'am.
She is assistant professor in Department of Radiology, Popular Medical Hospital. Even in her busy schedule, she joined with us. We are very much proud of you, Dr. Rupa. Now I request Dr. Tariq, who is consultant in radiology in National Institute of Neuroscience, to comment on these two presenters' presentation. Dr. Tariq, please.
Assalamu alaikum, and thank you everybody for inviting me here in the program. Though actually, unfortunately, I could not attend all through the program, but definitely it was an excellent one, and for concerned consultants and me from the radiology side, especially practicing to some extent some interventional procedures, definitely will help us a lot to upgrade ourselves. And I'm sure the concerned society will take such programs in regular interval, I hope. Thank you very much.
আপনাকে আমরা জানতে চাচ্ছি এদের আমাদের ডিবেটটা ছিল আপনি শুনেছেন কিনা আমি জানি না যে অ্যাডভান্স ইমেজিং উইথ পেট সিটি এন্ড এমআরআই ইজ এ মাস্ট ফর দি ম্যানেজমেন্ট অফ ক্যান্সার সার্ভিস ইন আওয়ার কান্ট্রি। একজন ডিবেটার ছিল এর পরে আরেকজন ছিল এর এগেইনস্টে যে পেট সিটি এমআরআই কি মাস্ট কিনা আমাদের দেশের জন্য, আমাদের মতো দেশে এটা সিএ সার্ভিসের ম্যানেজমেন্টের জন্য, এটার উপরে যদি
আমার যেটা অবজারভেশন যে স্টিল ইটস নট এ মাস্ট অ্যাকচুয়ালি, মানে আদার মডালিটিস যেগুলো আছে আমাদের সিটি স্ক্যান, আল্ট্রাসাউন্ড এন্ড এমআরআই, in most of the cases the problem can be solved with these modalities actually. PET CT should be reserved, I think. It should not be made must actually, because onno modalities যেগুলো আছে সেগুলো দিয়ে আমাদের most of the questionের answer করা সম্ভব।
আচ্ছা, Dr. Shahana, actually I want to take the opportunity to ask questions to these two busy radiologists of our country, to Dr. Rupa and to Dr. Tariq, my friend.
Yeah.
Can you hear?
Please, I'm hearing.
I want to know that is there any cutoff value of SUV max, that is maximum standardized uptake value that indicates cervical cancer? Actually, I want to know the interpretation of SUV max in cervical cancer.
Madam, can I say something?
Yes, of course. I want to hear from you.
We do not work PET CT, but what we know that there is no cutoff value for SUV of any tumor or inflammatory lesion or like this. That's the fallacy of PET CT. There is no cutoff value. So that's why if any uptake in the PET CT, it indicates carcinoma, it's not true. It may be inflammatory or carcinoma or anything. So there is no cutoff value.
Okay, thank you.
Is there anybody who can comment from any corner? If not, then I request our learned participant and the regular participant, Dr. Parveen Akhtar Banu, madam. Madam, please make some comment on these two presenters' presentation. Banu, madam, please. Madam, budhay nai. Beroy gechen. AK, please. AK, please make some comments.
Yeah, sure.
Yeah.
A great debate. I loved it. I agree with all the comments in the chat. What I would say is yes. Sure. And that's my comment. You know, if you have the resources, it's always nice to get more information. Information is power. You know, I think that if you have the ability to fine tune your understanding of the prognostic factors, I mean, that's ultimately what this is about, right? I mean, you know, the MRI and the PET CT scan give you more prognostic factors. They tell you a little bit more information about the size of the tumor. MRI is famous for helping us with parametrial involvement, where sometimes our physical exam can fall short, especially in the office. Under anesthesia, a lot of that straightens out. The PET CT scan, I mean, I completely agree that in general, a regular CT scan will show you a lot of things, but there is a little bit extra that you get from a PET CT scan. For sure, there can be false positives. Nevertheless, it gives you more information. For instance, you may identify on a PET CT scan that someone has a supraclavicular node that's positive or a mediastinal node, and all of a sudden you go from curative to palliative in how you manage that patient. So if you have the ability for more information, excellent. But, you know, it's very, very, and I think from a public health lens, looking at the big picture of a country and where you're going to expend precious medical resources, that's always going to be the balance. That's always going to be the balance. So I think that every time you think about it, these are the issues. So that's why I say yes, yes. If you can do it, great. If you can afford it, great. If you can't, I do think physical examination is very, very powerful, that we do have some basic radiology that's much cheaper. That is also very good. You may miss some of these fine things that are predictive of recurrence. But yeah, it's a wonderful, wonderful discussion. Thank you so much for all the hard work that went into looking up these papers. Very good and very current research. So I was very impressed with that. Congratulations.
Thank you, Eke. As the topic's name was, is it must for our country? Thank you. Is there anybody? Now I request Dr. Khadija Begum Jumi. She's head in Gynae Oncology in Dhaka Medical College Hospital. Appa, please, do you like to comment anything on your two presenters' presentation?
Thank you, Shana, for introducing me. Very nice presentation. I'm so much impressed by this debate, and it is my comment that as we are so poor in our country, the patients are so poor. If we spend so much money doing for investigations, they fail to get treatment, and ultimately the patient dies with disease. So we have to limit our investigation as the patients are so poor, and as the clinical staging is important, and in our country we should emphasize on this clinical staging and spend the money for that treatment, that is radiotherapy or chemotherapy or surgery, whatever they need. So in our country, it is not must for our country, but for, as Eke said, that fine tuning and prognosis prognosis depends on this investigation. Who can afford, we can do this investigation, but who cannot, we should not give emphasis on these investigations. Both the speakers, Fozia and Jasmine, stand efficiently on their points. Thank you so much.
Thank you, Appa. Thank you very much for your nice comment. Is there anybody can comment here? Dr. Roke Anwar, Dr. Jannat, Professor Jannat, Professor Roke Anwar, please.
Madam, can I say something about the madam's comment?
Yes, yes.
The clinical examination. Yes, ma'am, clinical examination is very vital, but the current figure staging, they also included the axial scanning, that is the imaging, because the pelvic lymph nodes, which upgraded the tumor, you cannot evaluate with the clinical examination. That's why that's imaging is very important, especially the MRI. If need any examination, that is any imaging is needed, MRI is the must before going through the operation or any further treatment, that is management for the patient. MRI is must for the cervical carcinoma patient. Thank you, madam.
Dr. Rupa, traditionally what we practice in our institute, if the clinical examination reveal that the disease is early stage, then we suggest to do MRI, and when the disease is advanced stage, then we suggest to do CT scan.
Madam, actually advanced means locally advanced. You means locally advanced, ma'am?
No, when it is inoperable, and then we suggest to do CT, because patient cannot afford both.
Yeah.
It would be better if they could afford both, but our patient can do an MRI and also a CT. When it is advanced.
The problem in CT scan, madam, what is the locally advanced CT scan cannot differentiate whether there is a involvement of rectal or bladder carcinoma. That's the main problem of CT scan, because both the tumor is soft tissue and bladder and rectal wall is the soft tissue. That's why the early invasion, that is the invasion, sometimes you cannot differentiate with the CT scan. That's the main problem of CT scan.
Yes. That is, but when there is every possibility in advanced stage, every possibility of involvement of the lymph node. So for better evaluation of the lymph node or any metastatic area, we usually suggest to do CT in advanced stage. And when it assumed that we can do operate, we suggest to do MRI.
Yes, ma'am.
Okay, thank you.
Thank you.
Dr. Ruqayya Anwar, Professor Ruqayya Anwar. Madam, please.
Hello, শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে, বলেন।
I have tried several times to tell something, but I think your time is very short. Both the speaker spoke very nicely, but both the speaker are working in Apex Center. So as Goodman said that if we depends upon the resource, the Apex Center should have MRI and PET CT scan. Just like BSMMU, they launch PET CT. So I think on Dhaka Medical College and NICRH should launch MRI and PET CT, because if this high modality technique available to our center, we would evaluate our patient very precisely. So side effect will be less and the outcome will be very good. I think so. This is my comment, and comment on presenter as they speak very nicely and very justifiedly. But if we think that still this is not the time to launch PET CT or MRI in this Apex Center, so I think we will go behind 10 to 20 years. So think it now to launch this machine, because all these modalities will help us to give treatment precisely. Thank you very much.
Thank you, madam. Thank you very much for your nice comment. Is there anybody who can comment, please? No junior, even now, no junior. Nobody has any comment. Please, junior doctors, you please comment something, or you please give your opinion regarding these two presentations or the journal presentation. This program is mainly for you, and we are just learning from you. Please. Taslima.
Assalamualaikum, madam.
Assalam. Give your comment, please.
আমি শারমিন রূপাকে একটা কথা জিজ্ঞেস করতে চাচ্ছিলাম।
Yes.
শারমিন রূপা,
please.
Which patient cannot afford MRI?
Rupa ki ase na?
I think Rupa is not available.
না yes বলেন।
Rupa, I am Taslima.
বলেন, আমি শুনতে পাচ্ছি।
Yes.
Rupa, I am Taslima. Which patient cannot afford MRI? In that case, we can use ultrasonography with color Doppler.
No, ma'am. There is no substitute for in case of cervical carcinoma because it is a soft tissue tumor. So we can substitute the MRI with the ultrasound with the color Doppler. This is not the substitute. It is only for the screening.
Okay, vaginal or transrectal ultrasound. Okay, please answer this question. In some patients who can even they cannot do the even one ultrasound. In that cases, can we advise her only transvaginal or transrectal ultrasound? Okay, please. Okay. Unmute yourself, yeah. Is there anybody who can comment?
Assalamu alaikum. Appa, I have a question.
Yes.
I'm Dr. Lutfa from Dhaka Medical College Hospital. We have a patient, we have see the patient previously that in our clinical examination, the parametrium was free and we diagnosed the case clinically, there is a CS cervix stage 1, B1. But on the MRI report, they revealed that both the parametrium was involved. So in our clinical examination, when we are so much sure about that parametrium is free, but in the MRI report that parametrium is involved. So we postponed the operation and send the patient for radiation therapy. Is it okay, or I want a comment from your expert opinion?
Yes, always believe your two fingers. Your two fingers is very important. Clinical examination is must. Clinical examination, it does not, we should not go through the report of the MRI or CT scan. We must go through the images. And even after that, sometimes we get these types of patients that clinically, we found that it is a stage 1B1 or either 1B2, but the imaging shows or the report shows, and sometimes they also imaging shows that it is stage 2B. But we did the surgeries in those patients and found that there was no parametrium involvement and anything. It doesn't mean if we do the MRI or other advanced imaging, we do not avoid our clinical examination. Our clinical examination is must. That is, we must believe our two fingers at first, then we go for the MRI. Rupa, please, or Dr. Kamal Bhai, please. Kamal Bhai, please.
Today debate was designed to explain that in this world, nothing is 100%.
Yes.
Every modality have its pros and cons, its strength and weakness. So this debate was designed to bring out the strength of the investigations like ultrasonogram and weakness of investigations like MRI and PET-CT. So that whenever we are advising something, as Shahana was telling, Dr. Jannatul, everybody was telling, the clinical examination, AK was telling, is the most important part, and it will be supported by the imaging. But everything is complementary. Nothing is, there is no single modality that is the, so there is no single modality which is 100% and which can give you full solution. So we wanted that discussion will bring up the strength and weakness, and the comment about the availability and the non-reliability is that, as Lutfa was telling, that if you trust the image, even you are not happy with the clinical examination, if you see that there is a doubtful area of imaging and the report is also in favor, then you can give a benefit of doubt, do overkill. Because in oncology, the recommendation is do overkill, but don't undertreat. So if there is a minimum suspicion, we should not go for some surgery where we may go for double modality, because we know we don't like double modality. But if the image is very clear and your clinical examination is very confident, definitely you can go for surgery. And regarding the another question of Taslima, that where there is no money, the answer is, if there is no money, you can do, of course. But one thing didn't come in the discussion is, it is not the investigation, it is the man behind investigation. Because we have the best MRI machine, but the reporting is not good. That may make a change. On the other hand, we may have a very average ultrasonogram machine, but a very expert hand may give us a very good report. Why Tata is so strength? Tata have done some study and they have found that their ultrasonogram report is 5% deviation from advanced imaging. So other than selective cases, they do ultrasonogram because they have their data and they do for it. But that cannot be a message for us. So we should depend on our clinical examination. We should select the proper modality. But most important is, when we select a modality, we should know who is doing the investigation. And also, we should not read the report. We should try to learn to read the image by ourselves And if there is any confusion, we go back to our radiologist, sit with him or her, share our concern that clinically it is free, why you are telling, because end of the day, we don't want to make a wrong judgment about our patient because patient is our target. Thank you.
Hello, Assalamualaikum. I am Dr. Rukhsana Parveen. I want to draw attention by Professor Shahana Parveen, madam. Madam,
Yes.
this patient who has referred from Dhaka Medical College, as Dr. Lutfa said, referred to NICRS for radiotherapy. I and Dr. Dina has attended the patient, and after pervasional examination, we also diagnosed as a case of stage 1B1. And after that, when we see the or check the all documents, MRI report was stage 2B, and we asked you, and you have reviewed the patient and said TBS advised Dr. Sharmin Rupa, and Madam also advised for admission and surgery. Madam, can you remember that?
Yes, yes.
Ji, madam. That patient which
Yes.
has referred from Dhaka Medical College.
Yes, yes. We did the surgery of this patient, and then
Ji, madam.
and the ultrasound report, and it was the ultrasound report. It showed that there was nothing involvement, anything, and just a small growth in the cervix. And we did the surgery very easily, parametrium, everything it was free, and we are waiting for the report of that patient. We did surgery in last 3 or 4 days back, after 3 weeks admitted in our hospital.
Thank you, madam.
Yes, it is true that sometimes patients do the MRI or CT scan outside hospital in a peripheral center. So in that case, we cannot suggest to do another CT or MRI in that patient. So in that case, I think a good ultrasonogram report, we can accept our clinical judgment and with the help of a good ultrasonogram report, I think. And also in 2001, there is a article which was published in Journal of Clinical Oncology that showed that a comparison study between the ultrasonogram and MRI, which showed that ultrasonogram has good diagnostic accuracy. So in the cases where MRI cannot be performed due to many causes, we can do that when already done one time outside the hospital, or patient cannot afford. Still, we have some patient who cannot afford. So in that case, we can take the report of a good ultrasonogram in expert hand, I think.
Thank you, Dr. Jannatul. Now it is in 10:45. Our president, Professor Dr. M.A. Hai sir, he left because probably his sir is sick. So I request Dr. Kamal Bhai to conclude the session.
So thank you, Shahana. Thank you very much to all the participants, especially the presenter and our overseas guest, AK, like always, and all the discussant and participants, especially the seniors, and also not forgetting the juniors, because as Shahana said, this program is designed for the juniors, and the presence of some seniors are always encouraging us, and we are hopeful that we will, inshallah, continue this program in future, and the support from you by active participation and your presence will encourage us to go forward, because we want to enrich ourselves, because there is no second option other than becoming knowledgeable. In this world, in the year 2020, we cannot survive without knowledge, and oncology is an extremely dynamic subject where everything is changing every day. So we need to really know what is happening, and this is the best way to learn from each other. So thank you very much, and hope to see you all in next week in our next session. Thank you very much. Allah Hafiz.
Thank you very much. Thank you very much for your participation. We wish you and we want you every time.
Thank you, madam. Good night.
Madam. Assalamualaikum, madam.
We always welcome you.
Thank you, madam.
Thank you, everyone. everybody.
Thank you, Shahana.
Thank you. আপনি এখনো আছেন, আমি খেয়াল করি।
আমি আছি। আমি তো আসলে ওই মাঝের একটা সেশন পারি না বিকজ মাই হাজবেন্ড হ্যাজ কোভিড, তো আমি খুব টেনশনে ছিলাম। এখন হি রিকভার্ড এবং ইনশাল্লাহ আজকে আমার বাসায় নেট ছিল না, আমি এখন দিয়ে করছি।
থ্যাংক ইউ আপা, থ্যাংক ইউ ভেরি মাচ। আপনারা যদি জয়েন করেন তাহলে আমাদের জন্য এটা খুবই, আমাদের আমরা সবাই।
আমি তো তোমার জুনিয়রের চেয়েও বেশি জুনিয়র, আমি এগুলো আই ডোন্ট নো এনিথিং বাট আই ওয়ান্ট টু লার্ন। যদি আপনাদের ডাক্তারদেরকে যদি আপনি মেসেজগুলি পৌঁছায় দেন, কারণ সকলের নাম্বার তো আমার কাছে সবাইকে পৌঁছাই দিই, একদম প্রথম দিনই দেই আসলে। থ্যাংক ইউ।
সবাই কষ্ট করে এত রাত জেগে আমাদের সাথে আছেন, এই জন্য সবাইকে ধন্যবাদ। আমরা আশা করি আপনারা রেগুলার থাকবেন
ইনশাআল্লাহ।
কামাল ভাই যে কথাটা বলছেন যে আমরা সবাই সবার কাছ থেকে শিখবো, আসলে সকলের মধ্যে প্রতিভা আছে, সকলের ভিতরে।
এই তো বলে সেটা কি কবি এভাবে বলছে, বিশ্বজোড়া পাঠশালা মোর সবার আমি ছাত্র।
জি জি, সকলের মধ্যে এই প্রতিভাটাকে, আমাদের উদ্দেশ্য শুধু মানে আমরা আসলে যেটা পারি নাই, আমরা যেটা মানে এটা যাতে জুনিয়ররা সেই কষ্টটা ওদের না হয়, ওরা যাতে আগে আসতে পারে, ওরা এই প্ল্যাটফর্মে কথা বলতে পারে, এবং শুধু প্রেজেন্টারই শুধু প্রেজেন্ট করে বসে থাকবে অথচ জুনিয়ররা কথা বলবেন এটা না, আপনারা সবাই কথা বলবেন। সবাইকে রিকোয়েস্ট, আপনারা সবাই আপনাদের প্রেজেন্টেশনগুলি পাঠিয়ে দেওয়া হয়, এটা সম্বন্ধে যদি একটুখানি দেখে আসেন, জার্নালটা পাঠিয়ে দেওয়া হয়, একটুখানি দেখে আসেন, তাহলে আপনারা কিছু না কিছু বললেই আমরা খুশি।
স্যারের কি শরীর খারাপ নাকি?
তাও কিছু বলেন। ঠিক আছে, থ্যাংক ইউ ভেরি মাচ। সামির শেষ করে দেন। সামির থ্যাংক ইউ। এই ছেলেটাকে সবচেয়ে সবার আগে এটাকে
ওই দিনও কিন্তু একটা প্রোগ্রাম থেকে স্যার খারাপ লাগতেছে বলে গেছে, আজকেও স্যার তো মানে মাত্র একটু দেখো তো কি সমস্যা, কোনো ব্লাডটা টেস্ট করবে কিন্তু।
সামির এই ছেলেটাকে, সামির শেষ করে দেন। আপনাকে অনেক ধন্যবাদ। এই ছেলেটা শুরু থেকে শেষ পর্যন্ত প্রতিটা ক্ষেত্রে দেখা যায় আমার মনে না থাকলেও সে আমাকে মনে করিয়ে দেয়।
তুমি আমার মনে একটু সিবিসিটা ডি ডাইমার আর সিআরপিটা করায় করোনা নেগেটিভ।
সামির শেষ করে দেন তাহলে।
থ্যাংক ইউ ভেরি মাচ।